Thank you very much. Good morning, ladies and gentlemen. As you know, my name is Roger Jackson. I'm chair of the Adult Social Care Public Health Committee. I'd like to welcome you to this meeting of the Select Committee, which is being broadcast live and recorded for publication. Can I take approval of the minutes of the last meeting, please? All those in favour to a correct record? It's okay if I sign them. Thank you. And I'll ask Kate if there are any apologies for absence, please.
Thank you. We have apologies from Councillor Steve Carr for medical reasons. Councillor Purdy Haran is here substituting.
Thank you very much. I will move on to item 3, any declarations of interest by members and officers. If any councillor or officer has an interest in any matter on the agenda, you should declare it now. Please raise your hand if you have an interest to declare. If an interest to declare, you should state what type of interest it is and give a brief details. Has anybody got any declarations of interest? No, thank you very much. So we'll move on now to the agenda, and agenda item 4, the social care market. And I would like to invite Councillor Barney, Cabinet Member for Adult Social Care and Public Health, to introduce this report, please.
Good morning, Chairman. Thank you. Just to give apologies from the Corporate Director, she will be joining us as soon as she can. She's presenting this morning somewhere in Nottinghamshire, but hopefully she'll be here at least for the last agenda item, which she hopes to lead on. If not, we're in the capable hands of Sue and the team here. So without further ado, Bridget, I'd like to invite you to present on this paper, please.
Thank you. I will just share my screen if I can. Yes, thank you. So we were invited to come back with an update on the social care market. I'm just trying to work out where the feedback is coming from. I think I'm slightly too close. There we go. And so what we've done is compiled this with a number of areas to give the committee really an update. So when we were first looking at this, if you remember, we invested £5.3 million last year in the care market. It was a mid-year uplift. And what we were looking at and invited to come back to talk about is the impact on the home care market. What we noticed is we have an increase in commissioned hours of 13.5%. So we're now running at about 27,500 hours a week. And it could be slightly above or slightly under that because that was July's figures. But the difference is to have an impact, a positive impact of 3,200 hours difference. So that money has settled the market, seems to have done what we hoped. From an outcome perspective, we're seeing more timely hospital discharges with less of a waiting time, and we're seeing reduction in interim care home beds on a month-on-month basis. So we're really quite pleased with how that has landed.
I'm terribly sorry to interrupt. Could you activate the slideshow mode so that it will present onto YouTube?
Of course I can.
Correctly?
Yes, I can. Thank you. In theory. Oh yes, there we are. Bless you, thank you. We also, at the same time as having that additional in-year uplift for the home care market, we removed the Quality 1 band for care homes. So we have 5 quality bands, but there were very few homes in band 1. And what we're wanting to do is to really have our homes aspire to be in a higher quality band. So we removed that band, and on the basis that most of those would have been our residential homes. We have sufficient residential capacity for our 65 plus market. We do have limited care home capacity, especially for nursing in Newark, but nursing can be more of a challenge, which makes us have to think a little bit more about what local is. We've seen some improvement in beds for mental health, people with mental health needs, and so that has improved slightly. But we are still seeing, for those of working age, some limited market capacity with more higher and complex needs. So that's what we're currently focusing on. Just to give you an indication, we've got 14.9% of all the care home beds are currently available. So that shows that we've still got some capacity. We had in September 2022, we introduced the Direct Payment Personal Assistant, known as the DPPA commissioning team. And what that does is it really helps us to source and identify personal assistance when people are wanting to have that option available to them. And that team worked closely with an individual or the family to identify and source that personal assistant for them. We've seen an improvement in numbers, and that's gone, if you look at it, from 12 PA packages a month to 23. So that is starting that at a much better place now. We were also asked to comment on our workforce, our external workforce. So there's been 2 social care careers events, one in September in 22 and one in October 22. We had 17 providers support the event in Retford, and 24 providers supported the event in Mansfield. They seem to be a really good success. We've still got 9.5% vacancy rate, but we do know that that sort of event really worked well for helping to bring more people in. So we are working alongside our care market to actually support the recruitment of staff. I ought to add just at this point that we're really pleased to have Volt Sacco here, who's sitting behind me on the right. He is the co-chair of the Nottinghamshire Care Association, as well as he leads is one of our lead providers in FOS healthcare, FOS care. So we're very pleased to have him here. So he can also help answer any questions if you'd like later. We're working at the moment on the development of an external social care strategy, and that is working with Skills for Care as an organisation to help us improve the understanding of the local social care workforce, and that is the independent workforce and those that work within the voluntary and community sector. What we're trying to do is really understand and set up priorities that are all jointly established, looking at the long-term strategic planning, market shaping and commissioning of the workforce, so that we are all saying and everyone's saying the same thing, and that's a consistent voice. We're looking at the sustainable workforce, and that is, you've heard that expression of right people with the right skills in the right place at the right time. That's really what we're trying to jointly focus on. And we're trying to get that sort of focus the workforce for, we need it to be future-proof. That is always a claim made, but it's really hard to achieve as the market forces do pull us in different directions. But there will always be a demand and a need for the workforce, and all levels, skilled and those new entry into the workforce. What we will do is that project will be fed through to the ICS Care Sector Workforce Steering Group, and that's co-chaired by both the City and the County Council. We have a number of innovations and projects we were invited to talk to you about. So we have the Surge service that did some work with us very much around January and June 2023. We were really struggling at one point to get that flow through from the hospital into the community, and it was primarily focused on reducing blockages in short-term home care-based services. And the provider was paid based on their capacity as opposed to delivered care. And so that supported the provider to help with, it's an innovation around their staff recruitment and retention. And you can see it's delivered quite a substantial amount of care at that period. We're also undertaking provider-led reviews. This is really quite interesting. It's part of an East Midlands regional approach as well as us doing this locally. So, of those, this is a provider carrying out a review of care, and the 47 reviews have been completed in the Mansfield area, with more planned. And actually, it's a cost effective and a resource effective method to use. We have to do it carefully, but we are looking at that, sharing and feeding that information back into the East Midlands system as well. We've also got a pilot around tech-enabled care, as you can imagine, and I know we've been here before talking very much about trying to get more tech savvy and to look at the opportunities that technology can bring into our service delivery. And this model was to look at helping people to remain as independent as possible, but what we wanted it to be least invasive. And it's been particularly successful where people are less willing to engage with care. So we've had 20 units deployed supporting virtual care. So this is really quite innovative model, and we're looking at that with the provider currently. So to see what that will mean, really around how you roll this out, whether you have one provider, for example, for the whole of the county, or you encourage everyone to use this, or what type of model to use. So that really is quite interesting. And to increase the use of technology within the market. And this is around really upgrading, helping our providers to upgrade their systems. So it is helping us to monitor and record falls, and it's a falls acoustic monitoring systems, and that will help us in that way. We've got some grant funding successfully bid for. I'll let you read the rest of that slide, but we've currently got 14 providers and they've received payments totaling 62,000 and an additional 65 expressions of interest that we're currently processing. So it's proving to be really quite a successful model. We've got a home-based care pathway pilot, and this is looking at the opportunities around a varied brokerage pathway for procuring contracted home-based care services. We're looking at the merit of a waiting list, a longer period for providers to review, and the impact of providers being able to see groups of work in order to effectively create runs. So a run being a shift that someone would do in their care pattern, so that you're helping people to have a run that is closer to each other, reducing the time travelling is usually what we would focus on. We didn't see an increase in the capacity and flow, but we may have been impacted by an increase in capacity in the first three pathways. So we're still analysing that one. We're looking at rural brokerage. Our cost of care exercise back this year, last year, really focused us on the need. We knew it, but it's helped us to spotlight really around the need for thinking creatively around rural packages of support. So we're creating a network and reporting tool to support the brokerage of hard to serve packages. Those who are really isolated, it can, if you're talking about an hour or so to travel to deliver care, it's not necessarily viable on current rates, etc. So we're looking at how we do that. Slightly changing conversational direction. We've had our annual conversation, and one of the things that came from that was a focus on caring and carers, the impact of how our carers feel around any care they access and support. And although we did have many people giving specific examples of how this support they do receive has worked well, and talk positively about the people who support them, we also saw quite stark examples of a lack of support, and particular times, evenings and weekends, inflexible arrangements that we need to focus on, unable to get support that will allow them, for example, if I give an example of what it means by the right support at the right time, wanting to nip out to get your hair done doesn't necessarily fall in a time to be able to get someone coming into you if your hair appointment could be at one time and the carers are coming in at another. So it's just sort of inflexible models. As well as people sharing with us really the personal pressures of caring and the impact on them and their health and well-being, and that real need for a break. I think point 6 is really quite hard to read, where you hear that people feel bewildered by what's going on, the isolation that being a carer can cause, and that feeling of abandonment. And some people step into the role of being a carer willingly, and others it just lands. And that, that there isn't a set model or a set style for that. Some people, it takes quite a while for them to realise they're a carer, and that's the role they're now in. So we're getting people at a different number of points in that confidence of being a carer, but we do know that we need to address caring and helping to support them in that role. What we're currently doing is we are working closely with the Nottinghamshire Care Association and really helping them to expand into being around not just care homes but all types of care. And that, I think, it's at its early stages, but it's looking really good. And as I said, Volt is here from the Nottinghamshire Care Association if you've got any specific questions. We're really still focusing, as I've said, on the rurality related care delivery and how that impacts, and whether we should have a different model, for example, for rural delivery. We continue to work with the ICB, that's the Integrated Care Board, and the City Council regarding working with the care market. So particularly with regards to uplift consistency and the development of more complex support. There's nothing worse than all of us coming out to the market with different uplift percentages, and we're trying to have a more consistent approach to that this year, and a more consistent approach to in-year requests where a provider says help or we need more, so that we all have a similar approach to how we respond in the county footprint. And we're also continuing to look at technology-enabled care solutions. That has to be a future for us. And we're looking at strengthening the use of technology within the department's work. So those are the slides. So I'll come out of that now and stop sharing. And then I'm happy to answer any questions that you may have.
Thank you very much, Bridget, for a very comprehensive report. Thank you. Do you want to switch your microphone? I'm sorry. I meant to say at the beginning, actually, the batteries are only just been charged to a certain extent, so they might run out. So if people's microphones do stop working, we'll just have to stop and change the batteries, if that's okay. So it's an indication for to be quiet. So so I'll move on there. Thank you for that. Social care is a very important part of what the council do, and there's a lot of pressures involved in running this, and it's nice to see the outcomes from the influx of the amount of money is improving the outcomes of what we're doing. And then the rurality of it is a little bit different. And to compare with the urban, being a rural person, I know there's lots of isolated villages and it's difficult, and a lot of transport and travel involved in that. And it's very interesting to see how the technology is helping and working. And I'm sure there's a big future there in modern technology and AI and social care and helping people in the future. Anyway, I will open it up to questioning. Eric.
Thank you, Chairman. Just a quick question on paragraph 3 of the report, where it talks about increase capacity is enable more timely hospital discharge and reduce waiting time. Do you have data on that, and how significant have those improvements been, and how do you expect them to improve even more in the future, please?
So sorry, I will get trained. We have seen that improvement, but the reality is that we are working together as a system on a single version of the truth, which is the dashboard that shows the demand as it comes through. Capacity-wise, we are seeing at the moment we've got more capacity in some areas than we can use even, and in some we are still struggling. So we are. It's not just about having the right capacity, it's in the right area and with the right skill set. So that is, yes, we are seeing that increase, and that increase is a general increase. But as we mentioned, rurality is really still the key, and that's where you can see the waiting times get worse at times. I don't know if that answers your question or whether you'd like something more specific.
Thank you. Reg.
You've spoken a lot about carers in the last part of your presentation. Can you give me a definition of who those carers are? Are they uncle, parents, father, mother, brother, sister, child, or employed, or put there by somebody? Who are you talking about there as carers? Because I've been through a bit of a cycle of that myself in the past, and I just want to know who you're talking about in that presentation.
Yeah, because just before you speak, Bridget, I just wanted to just remind the chairman that, and also acknowledge Volt is here. So Volt Sacco, it's a privilege to have Volt with us. So feel free, Volt, if you want to come in on any answers as well. It's obviously your experience is invaluable. But Bridget, thank you.
Actually, it's all the above, because you do have some people who are paid to be carers, but actually what we're focusing on at the moment are those who aren't paid, who are all age. So you can have children who are caring, brothers, sisters, aunts, uncles, can be partners, it can be grandparents, it can, it's everything. And actually when we listened and we did the big conversation, which was going out and listening, we really heard the fact that we've not got it where we need it to be for our carers, for our unpaid carers in particular. And it's how you support people really with that. So you get some who are sandwich carers as well, which is a wonderful phrase, but it's probably quite where you have someone who's caring for a parent, but they also maybe have children who also need care and support, and that can really have a double hit as well. So it is, it's not always straightforward.
Can I just supplementary that? So then, if we know what the complexity of all of this is, how can we get into the middle of it and improve it? Because that's where people, and I know I've personal experience in this as well, and I know where people sort of feel there's no support there for me, or some people say, yeah, it's good support there for me, but it's the one who feels there's not a lot of support there for me. How can we connect with them better than what we do today?
So it's a really good question. What we have is a forum called the Making It Real Forum, which has people with lived experience. And one of the co-chairs is someone who is an unpaid carer. And actually this last week we met, and we meet monthly. And last week's focus was very much on unpaid carers and what we need to do and how we can move forwards. We recognise, that this is not where we want it to be, but we're jointly working on the answer. So we are together working up a plan. We are together listening and continuing to listen, which is what we need to do. And it isn't just adults, we're looking at all age. We need to do that with our children and family partners so that we're getting that right. But yes, so we're not there yet. You'd be surprised if we're reporting in a slide set that we are at a sort of low base. I think what you'd find is that most places are at a low base. So this isn't just a Nottinghamshire County Council issue, it's a national issue. What we're doing is saying we want to do something about this and prioritise it. So we are working with people with lived experience and have that fora to continue to listen and continue to work together on a plan that we jointly address.
Well, watch this space, Chairman.
Thanks, Chair. Yeah, thanks for the report. The first paragraph sort of highlights the impact of what we've been doing to me, where it says we've still got the problem with and difficulties with recruitment and retention of staff, and I think that sort of theme actually goes right through the report in various paragraphs. Despite what we are doing as as a council to improve the situation. And there are some good stories coming out of the report. I still think that the underlying problem is trying to get, and I'm talking about paid carers now, not as Reg mentioned about unpaid carers. The difficulty is to get people to come into the care profession and actually offer themselves to be employed. Looking at the events that we actually put on, I think the actual numbers that were coming to look at what uh, providers were offering in relation to employment are very poor, and I think that in itself is something we ought to reflect on and look at what possibly we are doing in relation to these events, because although there are a few people come forward, how many of those people actually were employed in care at the end of the process? And that sort of information to me is something that we need to look at and work on. If we talk about the 5.2 million that we actually put into the situation, I think what we need to do is, and I'll ask Mr. Sacco this, of somebody that's in relation to Nottinghamshire Care Association, so he is looking at possibly care providers throughout Nottinghamshire. What is the ongoing theme with providers? Are people offering themselves now to become carers, or is this still a problem because of wages and conditions that people find themselves in when they actually enter the care market? So I think the report is good, and it's putting some valid points forward that we are making an improvement. We're blurring things on the edges, but there's still an underlying problem, and I think this is why the impact of this report needs to continually come back to this committee for us to look at and assess it, not just come to one committee, because we've been doing this since October. We've been looking at it, and the theme is still a problem with recruitment and retention. So I think it's something that we need to keep revisiting and keep bringing back to committee. But I mean, they're just a few comments on that, Chair. So I'd be interested to hear what Mr. Sacco and other people have got to say. Thank you.
Yeah, Bridget could perhaps comment on the jobs fair aspects, and if you can't comment on the other. Thank you.
Actually, what I was going to say is it would be really interesting to hear Volt's view on this. So if I might hand over to him, I think then you're getting that view from the market. Yeah. Yeah.
Okay, can you hear me okay? Yeah, so I think first of all, there has been an exceptional 2022 in terms of the recruitment pressures across the UK, really. The other dynamic to consider is we are in a sector where we can't do discretionary pricing. You know, Aldi could put up the price of the shopping by 10% and increase the pay by £1. Social care can't quite do that. So there are some realities which I think will carry on going forward. But the 5.3 million that was spent, from a provider perspective, that early intervention was really welcome. It would have been a very different winter otherwise. And some of the feedback that we had from the workforce was particularly around how they felt in terms of the morale and the feeling valued. The fact that there was a recognition that the pressures are there and something was done about it. And that moral aspect is really important. We often talk about the pay as the key points, and that's true for all of us. But they felt valued, which was really, really important. There are issues, the other thing that really mattered to carers, which the uplift allowed us to do, was to provide them with some financial stability, which in turn provided continuity of care to the people in receipt of care. And therefore that was positive outcomes for care recipients or people who are using social care services. So yeah, I think touching on that 5.3 million, the improved retention, the improved recruitments were certainly seen, but there was also a morale boost to the workforce.
Thank you.
I think the point for us is it's such a flexible market. We know we need certain carers in certain areas. I mean that's the issue. We have quite a few in certain urban areas, and not necessarily a lack there. But as soon as you go anything off the norm, it can become really difficult. And so, we can't do this in isolation. We are working with the Care Association because that's what we need to do. We need to listen to the issues, any of the challenges, and be much closer to the market. But we also need to think differently. And so, obviously, those innovations and things we talked about, which we're looking at, whether that's tech enabled care, virtual visits, that sort of thing, is it has to be a way forwards because it will help us with some of those care needs. Not all. You can't do a virtual visit for everyone. Do you all know what that is? Yes. Okay. Sorry. Just didn't want to say something and make an assumption.
Thanks very much. Yes, I mean it's the challenge of our lives really to look after an aging population. It's not immediately clear with a population that is increasing in age whether we're standing still with the increase in the number of people over certain ages requiring demand, or we're actually getting ahead of that and improving what we've got for the numbers that we've got. Capacity, it's sort of a bit like wind turbines out at sea, and you get a great blowy day and some great energy, and then you have to see how can you make that work across the rest of the year. And I can see that we got some capacity. The 14.9% wasn't immediately clear to me whether we have booked that up and we've got it in reserve, whether that's what we're currently using up, whether that's an existing capacity within the system. And at this time of year, you have to look forward and say, what have we got for winter? Last year, winter, there was things called care hotels, where people were booking up hotels and moving people from hospitals into hotels. There was Kingsmill Hospital taking over whole bottom floors and retirement homes and nursing homes. There was obviously the virtual wards, etc., going on. And although the wind turbine is producing some power at the moment, what have we got that we can carry over towards winter? I think it's also a great time to remind all care staff to get out and get the COVID vaccinations, because there's a new surge of COVID out there, and quite often you get lulled into a false sense, and then you find that your workforce not only can't be retained and recruited, but is actually off sick, which is quite important from that point of view. So looking forward in terms of the technology, it's great to see that, Bridget, and very welcomed developments in terms of the funding that's come into that. I was asking the same question at Kingsmill Hospital recently, saying if they're discharging people, are they using tech support to do that, like they're doing with the virtual wards? And you not only have the technology that somebody puts in an acoustic or a movement sensor in a person's house or home, but you actually have the challenge of maintaining that, which is often the monthly charge as opposed to the installation charge. And therefore, these are rolling costs as opposed to one-off grants that you can give to people to put in something, because if you don't have the long-term maintenance of it, then it gets switched off and then it's of no use to anybody. So in terms of that, I'd like to know if there was a subgroup on behalf of the ICS which is trying to coordinate, say, the hospital using funds for early discharge to support people, private individuals with their own support, the local government with what it's putting in to maintain people, and whether there's a coordinated approach, the one system approach to maintain and develop what is only going to be a bigger area. I think it's quite exciting. So I loved seeing that up. So have we got, or is it too early to say yet, the one system approach to technology, particularly around the long-term maintenance of the contracts that update the equipment and keep them functional, as opposed to one-off 18,000 pounds to providers for one-off installation? So that's me, Bridget.
So if I've made a couple of notes. So just 14.9%, if I start right back where you were. The we get a capacity tracker, so we can see what beds are available, and so we broadly know that it's. And I will say broadly, because just because there's capacity doesn't always mean that it's staffed. People, if could have a unit that's closed in a home. So we know that that's our capacity currently. So, but that also means if you put it conversely, those beds aren't bringing in income for the care home. So we have to be careful that that doesn't get too high if there are, if we're trying to keep our number of beds available. But at the moment, that's how that's calculated. You talked about variation in need and ongoing costs, etc. So we obviously need to make sure that we use technology sensibly and wisely. You mentioned virtual wards. We are looking at that, and that will carry on. I think we've managed to avoid some of the other scary things that you mentioned. But some of the sort of hotels and things, that model, but because that always fills me with slight dread in how you oversee and manage and support people in those settings. But that doesn't mean we still have to keep innovative. And I think the idea of technology, anytime we've got the pilot at the moment for virtual visits, so you have a technology in someone's home. Actually, obviously, we have to put that ongoing maintenance into that. There is a question, and this is something we're looking at the moment, is actually if you have, like we use a bring your own device for our phones and things, is actually there's one thing about having specialist tech and when you need specialist tech, and the other, which is if someone at home has their own laptop or some sort of tablet of some sort, should we just be looking at an app? So all of those sort of conversations are ongoing. But if we choose to have a particular bit of kit, then we have to always factor in the costs for maintenance. Just to say that we're not just doing this; we've got the colleagues in health who are also looking at this. So what we're doing is joining that together, so we just don't all go off on our own little ways. So yes, yeah. Sue, come in.
So just to pick up on that, it's a really good question that we're working together and now we're looking at the point of hospital discharge. We're working with some consultants who are really experienced at digital opportunities, and we're working across community health and social care, looking at how we can make sure that we are maximising digital at the point of discharge, because we don't put long-term home care in at that point. It's social reablement and health recovery from community health. So we're currently having a diagnostic undertaken of that. And also we're looking at the opportunities for crisis prevention to stop people going into hospital. And we're working closely with Connected Knots and the ICS, which is the overarching digital strategy. And we're looking at linking into some work that the city have already done. People might have heard of a Lily project there. So yes, we are starting to join that up and using some of the National Discharge Grant to get that work going.
Thank you, Bridget. Sue.
Thank you for that. Any your question, Mike?
Thank you, Chairman. Thank you, Bridget. I'm going to raise a couple of points for yourself and then one for Mr. Sacco, if that's okay. Let's just put everybody's cards on the tables. If we had a magic wand and we could sort all this out in one hit, we would do. Each and every one of us would sort this out immediately. So when we come to, it's difficult to question the detail of your hard work and efforts when, in particular, in paragraph 11, A says many people, B says a number of people, E many people, F some people. It's difficult to understand the detail of who we're actually talking about. I don't think there's any shame in putting the numbers in. I think it's a positive for us to work on and see that increase as we move forward, because we are moving forward, there's no question about that. I'm assuming, Bridget, paragraph 11 references to paragraph 12 with regards to digital side of things. It'd be really good to have you come back some point
and see how we're moving on. I know that partners are working together, hopefully to have it, which is an absolute common sense thing, to all work under the same programme, which can be interchanged with each other. That's an obvious thing, I think, to move forward. Councillor Doddy, stop jumping in, okay? I wanted to say about winter, because we are definitely coming to that period, and are we prepared in the care service and hospital releases for winter? I think we should bring that up now with the programme of meetings that we have. And I hope it's positive, Bridget, I really do. Mr. Sacco, we're talking again, because we have this, as everybody does nationally, the recruitment, retention of recruitment. And if we recognise the 5.3 million which was given by council and the positive of that, then we have to recognise the point in 11F which Bridget raised with the comments. The frightening, bewilderment, isolation, abandonment. That's the last thing I want to read in a paper. And when I do read it in a paper, I'm looking at having some sort of immediate reaction to correct this. So I'd look to see what's happening there. But my main concern is that I'm assuming that continual private sector investment through government, what's available at government, has a huge impact on us because we're not competing. And if we do compete with wages, then the suggestion is that if wages are the control of the care service, then private sector will just increase their wages and demand more from government. So what's the link? How do we break the link between the private sector dominating the care the care employees that we want to engage with us, for us to provide even greater care than we do? Thank you, Chair.
If I start, and then Volt, if you want to come in at any point, just on, I'm going to start with one of your last points about paragraph 11F. That relates to unpaid carers. So someone like myself, I was my husband's carer, my children were young carers. It wasn't about being an employee of or being paid to care. So I think. So I think.
Sorry, I've got to come in. I'm really sorry, and I'm on your side. But carer is carer, whether they're paid or not. And if we are recognising this by people we are seeing, then I have a serious issue with it, to be quite honest.
And that's what we have. That hence the focus through the Making It Real forum and the focus for the department. So absolutely not disagreeing at all. Stats in this, there is an update if you want on the big conversation as well, and that talks about the some of the stats and figures within this. So the big conversation being that the meetings that happened out in the community. So that does have some of the stats that flow into here. So where it says some and several. So I do take that on the chin that it's not the easiest to read when you're wondering how many. Just on digital, happy to come back with more information on digital. I think that's an area that we've got to really focus on. I think that's quite an emphasis. You talk about winter preparation. It's very difficult to get winter right because you just don't know what the flow through is. And so we work as a system to determine what the sort of current flow and demand is and base it on previous years. But equally, you can only do that together. And you have to also have very responsive lead providers. We are lucky that we do have responsive lead providers here who will help and work with us. We start working on winter in August, which I know sounds bizarre, but we do. And we work on that with all the system partners to make sure that we are forecasting accurately what's coming through. We're not there yet. You wouldn't expect that, but winter does start in October from the hospital point of view and will last until about April, May with the impact of it. So that is what we're currently doing. if you're saying, are we ready? We have to be ready. But we also have to be responsive and reactive. We don't want people, in fact, just before we came down here, Volt and I were talking about, we don't want carers sitting there twiddling thumbs, because actually if you have too much care, people go off and out of the market. So you have to have enough to have capacity, but not too much. So that is a really difficult, fine-tuned picture. And also we have to buy enough so that we have new capacity to pick up care over Christmas, when actually a lot of people who are in the care market can be women, and some of those want to be around with their families over Christmas. So it's all of those balances, but that is what we're currently working on.
Mike, those words also resonated acutely with me when I read them in the report, and also, and I was happy for them to be left in the report, because I don't think we should sweep under the carpet the reality of what it's like to be a carer day to day. And again, when I saw them on screen, I was privileged a week ago last Sunday to spend the day with a carer in my ward, who's looked after her sister for many years. She herself, the carer, has significant health challenges, but she's been looking after her sister, who's not all that old, but has been deteriorating with dementia. And exactly those three words pinpoint her experience, because spending so much time with that close loved one, looking at, and it's love that drives it, of course, in that family bond. But then as that person doesn't even recognise anymore who she is, you're increasingly left abandoned and isolated. And there's people like that all across Nottinghamshire. So privileged for me to spend time with this lady, but absolutely, we have a corporate duty and responsibility of what we can as a council, but I think there's also a social and moral responsibility as community, as people, as individuals, outside of politics, to reach out and to provide love in our communities and support for those individuals that go so often unseen, and their day-to-day reality if they're working so hard caring. How many do we not know about? So thank you for raising that. Sorry to step in.
Yeah, I mean, it's very sad to read that. Is reality of what's happening in the county, and it's not what anyone would want to ever see to any of our loved one and friends. I can't comment about the private versus council recruitment, but what I can tell you is that the Nottinghamshire Care Association, which we started only a couple of months ago, is working very closely with Bridget and team. We have monthly meetings. We carry an action log. It's happening. And part of that is to try and reach the parts of the systems are difficult to reach, and to support the local authority with that. And one example of it is that we've already started winter planning. So we need to build up memberships. It's only been going on for a couple of months, but I'm hopeful that as we do that, the joined up approach we're taking on with Notts County is the right one.
Vote.
Just a quick one, Chairman. Okay, so I don't want my comments to be solely on 11F. Okay, I recognise there's a myriad of efforts going in to correct this, as you say, and that affects us all governments of this, and it should impact us all to make sure this is not the case. And if there are individuals, that shouldn't happen. And 2 months, I get that, but you've not been aware of the critical situation for 2 months. I know that you're clever than me with that. So I'd expect future responses to come back with an idea, because at the minute, apart from the efforts of which is being carried out, which Bridget has reported on, and the social media approaches, and we've got 30 people here. How are we going to increase that and maintain a high percentage of those people that we train? That's the sort of thing I'd be looking at. Thank you, Chairman.
Thank you, Mike. I don't think there's really a question there, but thank you. Cyril.
Let's follow that. I have had quite a extensive experience of being a sandwich carer, so I mean the support of carers is absolutely vital. My question was going to be the tech-enabled care units. Is this pilot, is it in a specific area, and how quickly are we looking to extend that?
If I can come back in on that, we are currently working with the provider to evaluate it. There is an evaluation that's being carried out, and the question is not about really its success. We know it works, but it works with specific cohorts of people with particular demographic needs than it does for others. And so what we're looking at is how you then roll that out. So if you've got more specific questions, we could possibly answer those, but it depends whether you want that or you'd like more of an update brought back.
I think this is a subject which will come back to this committee for further scrutiny in various reasons. Yeah. A quick one.
Presumably, so the debate's winding up, but it does say in the report any recommendations that we ought to push forward as a committee, and I'm just going to offer a few recommendations if that's permitted, Chair. But I'd like to just go back to the point earlier about valuing and staff feeling valued. I mean, I think one of the best ways you can say to a member of staff or to a team is and that they're valued is with the amount of remuneration that they get. You can tell them all as many times as you like that we do value you, but at the end of the day, if they haven't got enough money to pay the bills at the end of the month, they're going to struggle. So I think it's a myth to say that if you just say to a staff team that you're valued and support them, the ultimate way to value them is to give them a decent wage. But in saying that, I mean, out of the 5.35 million to Councillor Barney, how much of that money did you actually think was going to be given to providers to uplift people's wages? Because, I mean, as you know, some of the money hasn't been used for that purpose, or should it have been used for that purpose, or did you think it should have been used for that purpose? And if it hasn't been used for that purpose, why then hasn't it? You know, so that's just one point I'd like to make. But in regard to the recommendations, I think we've got to really point out that the impact of this report, and it really worries me in relation to the first paragraph where it says, there are considerable pressures within the social care market that impact on the council's ability to meet its statutory duties. So in itself, that's a concern for me. So that is why I would suggest that we as a committee keep revisiting this and keep coming back with further reports and further information. We touched on the job recruitment fairs, and I think there was a consensus from people that did speak that we need to look at that, and we need to get a further report on how we're possibly going to improve that to try and get more people to go into care. That's something that we could do. And then we can touch on the a recommendation regarding the virtual technology. Come back, and I think Bridget did mention this, come back to a future meeting and how that is progressing and how we see that to develop to improve the care of the people of Nottinghamshire. So I'd just like to offer those chairs a few recommendations.
Thank you, Paul. I think Martin's got some of those written down. Yeah. I mean, this is a very big subject and a very big part of what the council and the work the council do, and it probably needs stripping down to scrutinise different elements of it in the future. Because it's a very broad paper at the moment. I do thank Bridget and Volt for the information and the replies they're given to some very in-depth questions. So I do thank you for that. Martin, have we got a recommendation?
Yeah. Sorry, no particular order because I've just written them down as they've happened. But please correct me if you'd like anything else adding on there. So obviously, firstly, the report is noted. The details of the outcomes of the big conversation be circulated to members of the committee. That further information on the use and rollout of technological care solutions be circulated to the committee. That a further progress report on the social care market be brought to a future meeting of the committee at a date to be agreed by the chairman and the vice chairman, and the focus of that report can be agreed near the time, so it can have a focus on recruitment or whatever. And that a report on the work that is being carried out to support carers be brought to a future meeting at a date to be agreed by the chair and vice chair. Does that cover everything?
Thank you, members. Are you happy with those recommendations? All those in favour? Thank you very much indeed. And we'll move on now to agenda item 5.
Just call slightly closer if we've got something tomorrow.
pause to.
Just pop the microphone first.
Oh, okay. One moment. I'm just going to sort a microphone out. Okay, we're all wired for sound. Agenda item 5, another health check programme. I'd like to invite Councillor Barney to introduce the report, please.
Thank you, Chairman. So we have 3 esteemed members of our Public Health Committee with us here this morning. I believe, Jonathan, are you going to lead on this or straight to Jeff?
Is that working now? Yeah, great. Thank you. Thank you. Thank you, Chair. So for those of you that don't know me, I am Viv Robbins. I am Deputy Director of Public Health, and thank you for having us today. So I'll just do a brief introduction in terms of why we're here today. So we're here to provide yourselves with a summary of progress on our national mandate to deliver the NHS Health Check programme, and really giving you a bit of an update in terms of where we are at in Nottinghamshire, what our practical delivery is, and our performance post-COVID, but just giving you a little bit of an indication in terms of our next steps as well, and really thinking around how we can have that more equitable approach, so really making sure we're meeting the needs of our most vulnerable populations. So in terms of the NHS Health Checks, for those of you that may not have heard of these before, these are health checks that are a mandated service for public health, so they are paid for through the public health grant. They aim to improve the well-being of adults who are aged 40 to 74 years old, really trying to increase that promotion of awareness, assessment and management of major risk factors of cardiovascular disease. So what we're looking at here is conditions of the blood vessels and the heart, and really acknowledging the really important impact that cardiovascular disease has in terms of it's a significant cause of morbidity and mortality in Nottinghamshire, and a really important thing to consider here is that 85% of cardiovascular disease is preventable. So if it's okay, I'm going to hand over to Jeff to take you through a little bit more of the detail, and then obviously we're more than happy to answer any questions or queries that people have at the end. Thank you.
Thank you. My name is Jeff Hamilton. I'm the Senior Public Health and Commissioning Manager working in Viv's team. So, as Viv said, it's essentially health checks, which have been around for about 15 years and are a national programme, are basically to screen people aged 40 to 74 years against cardiovascular disease. And it's an early intervention type of programme to try and spot things early and then deal with them. You're eligible for a health check. Everyone's eligible as long as they're between 40 and 74, unless they've already got heart disease or have had a stroke or cardiovascular episode. And you're eligible for a health check every 5 years. So if you're within the 5-year period, you get a health check, and then 5 years later, you'll be invited for another one. Obviously, as Viv said, a lot of it is preventable, and the impact of a stroke or such like on the individual is obviously severe, but also on the system as a whole, and it's something that's much cheaper to invest early in than to sort out later, both for the NHS and social care. And there is a statutory duty under the 2012 Health and Social Care Act for local authorities, upper tier and unitary, to commission a health check programme. So although it's called NHS Health Checks, it's not really an NHS-led programme, but it's most often provided by NHS providers. In Nottinghamshire, we have traditionally used GP practices to provide NHS health checks, and have commissioned them since the the local authority took on public health, and pre-COVID it was fairly successful, worked well, good engagement across the county. Post-COVID, obviously, huge pressures on primary care, catching up with missed vaccinations, etc., and screening programs. So it's becoming more of an issue at the moment to try and pick up the program again after the pandemic. We're making progress and getting there, but it's slow. So if you have an NHS Health Check, you'll have your blood taken, and the blood test is to check for your cholesterol levels and to check for diabetes, your blood sugar. You'll also have your blood pressure taken, and the healthcare assistant or nurse will take your pulse to look for something called atrial fibrillation, which can be spotted through an uneven pulse. And they'll weigh you and take your height to find out your body mass index, and then you'll also have pre-completed a questionnaire on your alcohol intake, and they'll come up with a score which assesses your risk from alcohol, and also ask you if you're a smoker, how much exercise you take, and check on your family history of heart disease. And obviously your age and gender are very significant factors in terms of risk. And they put all of those things into an algorithm which comes out with a risk score, and it's called a Q risk score. And this is a kind of internationally standardized risk score for your potential for a cardiovascular disease episode within the next 10 years. So you might come out with a 10% risk of having an incident within 10 years, and then you'd be classed as medium risk. If you come out with a 20% risk, then you're classed as high risk, and you're immediately referred back to the GP for further tests and possibly onto more specialised tests. So 20% is the high risk and the one to worry about. Anything below that is you still receive advice from the clinician, and maybe a referral to support services. Maybe medications such as statins will be given by the GP, but you're still within the NHS Health Check programme, and we'll come back in 5 years' time. So in Nottinghamshire, we have a very sophisticated computer programme developed by the Integrated Care Board, which can dig into everybody's clinical record on the GP systems right across the county. And it's called eHealthscope, and it digs out, it goes in and it works out your potential risk score without even seeing you. And then it will make a big list of all the patients who are eligible that month based on their risk, and it stratifies you by risk. It looks at your smoking status, your weight, and your other risk factors. And practices can use that information then to invite people to come for checks, and they can then target patients almost individually based on this software. It's not perfect, obviously. If you're not registered with a GP, it won't work because you're not on the system. And also, if you've not seen a GP for years, it won't know your weight or your smoking status, etc. So it's far from perfect, but it's good on the whole at targeting. And we've used this for about 6 years now. And practices are paid per check per person seen, and they're incentivized to see the high risk patients. So if they see somebody with a Q risk of above 20%, they get paid a bonus payment of £38. So it's £18 for a check, and then an extra 38 on top of that for a high risk patient. We also have a very small service which is run by a pharmacy, which goes to workplaces and does NHS Health Checks workplaces on people who can book in there to save them having to go to the GP, and it's really to enable easier access to health checks. It's only small there at the moment, and but we do target the workplaces according to the likely risk of the people working there. So we tend to go for male, manual labour type workplaces. And in council, we try to market the programme. Pre-COVID, we did quite a lot of communications through libraries and other venues with sort of posters and banners, and we also do social media. Post-COVID, we've done much less because we're very conscious of the pressure on primary care, and we don't want to cause a deluge, although it's picking up now and capacity's getting better, but we still have been careful not to overdo it. But patients are able also to just have an opportunistic check. They don't have to be invited. They can phone up and book one in, and all practices are signed up to provide them. I hope it's clear enough on the screen. But this is our performance over the last 10 years. The dotted line is the invitations that have been sent, and the orange line is the actual checks that have been undertaken. And you can see that pre-pandemic, we did 5,000 to 6,000 checks per quarter. The invites kind of bump up and down because they're quite seasonal. It depends on the capacity of the practice. They may choose not to do many checks in the autumn when they've got lots of flu vaccinations perhaps to do. But in the summer or around Christmas, January is a very good time when people are making New Year's resolutions. They'll send more out. So it's up and down. And then you can see the crash that came, obviously, with COVID when everything stopped for a year and a half. And gradually it's been picking back up again. Not quite to pre-pandemic levels, but it's on its way. And it's a fairly encouraging, I think, picture. It could have stopped completely, and we're pleased it's picking up again. Another way of looking at the data for the last 5 years is perhaps a bit small on the screen, but on the left-hand side we have the invitations that were sent in the 5-year period, and on the right is the checks that were done. And this is a 5-year rolling average of a set cohort of people, 5-year cohort. And on the left you can see the blue line, which is the England figure, is, in terms of invites, is at a higher level than ours in Nottinghamshire. So on average we send fewer invites out than the rest of the country. We're about on a par with the East Midlands. And on the right hand side you can see actually the uptake of those invites, the number of checks that are actually done is better than the England average. So although we send fewer out because it's very, very targeted according to the individual's risk, the number of checks actually undertaken is relatively positive compared to statistical neighbours. And we've been like this really throughout the programme. We've been sort of just above average against the national picture in terms of actual coverage of NHS Health Checks. And geographically, this is the spread across the county. On the left again is invitations, and on the right is the number of checks actually done. On the left, the darker purple is a better outcome. So Bassetlaw and Mansfield Ashfield send more invites than the rest of the county, and to an extent you'd expect that because the demographic connected to cardiovascular disease is often more around deprived communities. However, on the right hand side you can see the actual coverage, the uptake is more south-based. People are more likely to take up the offer if they're invited. Rushcliffe's obviously quite green there, and we would expect this from a theoretical point of view, that the people more likely to take up an offer of a health check are probably the worried well, as they're called, who are going to get themselves checked as they can. The ones we try to get in through the GP's door are those who really are at risk and need to be referred for more checks. So this includes the pandemic period, so you'd expect it to be much greener and more purple. The figures are lower because of the long gap that we had. But that gives you a kind of idea of the scale. And pre-COVID, we also we took a policy position to not just focus on quantity, but also on quality of checks undertaken. So we, through this software called eHealthScope, can check how well each practice is completing its clinical template. In other words, how well it's completing its health check. We can check this from afar. We're obviously not sitting there, but we can see, and here's an example from Mansfield Ashfield. Each practice, there's 23 of them in the area, and each of them have to input the data onto the template, which might be around ethnicity or cholesterol or BMI, etc. And we can see where they may have missed doing that properly. They may have short-circuited the template, may have used the wrong template, and then we can support practices, and it might be a training issue, one member of staff perhaps, and we can get them to do the health check more carefully next time. So that's been quite a lot of our work actually has been trying to increase the quality, and 3 or 4 years ago this would have been fairly red. So it's really, really improved in the last few years. But obviously there's lots more that can be done, and we're far from perfect in Nottinghamshire. There are other ways to provide health checks. You don't have to use GP practices, it's totally up to the discretion of the local authority. But the vast majority, in fact, I don't know of any local authorities that don't use GPs. You can, however, use pharmacies. or commission a private provider to do health checks. Some councils have tried using their local lifestyle services that they're commissioned through their own public health services. And there's also a digital offer evolving, which the government is rolling out nationally in the spring, gradually. And there's pros and cons. It's obviously another provider would take that pressure off GPs and would enable more resource to be targeted to the programme, which would be good for the population, obviously. And there could be better access through longer opening hours and longer consultations, etc. But the real problem that we've and the rest of the country faces is that in order to invite people, you need to know who's eligible. So you need access to the clinical systems, System 1 and EMIS. And without that, you don't know who to invite, because you have to know who's eligible and who's ineligible, what their age is, what their history of CVD is. And if you had a private provider, say, running it, they would have to have an information sharing agreement with every GP practice, all 86 of them, in order to get into the system. So we've grappled with this for several years. I don't think anyone's found a good solution, but we'll come on to that in a second. The other thing about GPs is that they're trusted. They're very the badge NHS is still very trusted in terms of all health, but obviously for a health check to be run by perhaps non-clinical staff may be an issue for some patients. And also we run the risk of paying for checks that are done on ineligible patients, which would be not desirable. So we're looking, and we have been looking really for several years, to try to augment the GP offer. We have the outreach service run by pharmacy, which has been positive, but we've also tried to work with primary care networks to develop new models that practice could follow, such as a lead practice taking on health checks for their entire primary care network. So patients are checked by that practice that's most engaged with health checks, and they may go out to the satellite surgeries and do the checks there, or patients could go to the main practice, but that may create its own inequalities if they can't get there. We did try to roll this out earlier this year. We didn't have very much interest from current primary care, but they are under huge pressure, and it's something that we need to try again. Another model that could work is a subcontracting model where practices sign the contract, but then commission someone else to do the work for them. And that gets around the issue of invitations and accessing the GP system, because the GPs could invite the people and someone else could provide the check. But it's a more expensive arrangement and perhaps arguably less value for money. But these are things that we're trying to look into and take forward. And also we did a health equity audit recently to try to work out where the inequalities were in more detail. And we're going to assimilate these findings, especially around deprivation and trying to target more in those areas where practice perhaps are under huge pressure in those areas but still need to do these health checks. And the pandemic also brought to the fore some vulnerable groups where we've been missing those, for example, homeless, who aren't registered and therefore can't be invited easily. I think that's probably it. Happy to take questions between us.
Thank you, Jeff and Vivian, for giving that report. Yeah, so and good morning, Mel. Welcome to the meeting. Prevention is always better than the cure, and I think this is a good step to try and get forward with that. To help people. It's probably one thing we need to look at is actually encouraging more people when they're sent invitations to actually take it up and go for their health checks. But is another thing that I know we'll definitely work on and find more providers. But I will open it up to a question. Philip.
Yeah, just one point. Thank you, Chairman. Really, the health check programme aims to improve the health and well-being of adults, and that's fine until you get to 75, and then you can. That's it. We're not bothered about you anymore. Why? What's wrong with being 75? Apart from the fact that we can't get a health check anymore. I would have thought that was exactly the time when we ought to be thinking about giving health checks to people. I've looked at the flowchart, if that's what it is, on page 23, the NHS Health Check. I suppose if you can work your way through all of that, you can assume you're not suffering from dementia, so that's a help. But that doesn't really help. Um, if we're not going to get the services, then perhaps you can notify HMRC and they can cut my tax bill because they certainly charge me enough for it. And I would just make one other point on performance. We seem to be very blasé about performance, but in round figures, half of the eligible people are invited. Only half of those that are eligible are invited, and only half of those that are invited actually bother to turn up. Now, if that's the situation, it's not very good, and you can't force people to attend. But it does mean, in my view, you could actually ask those 75 plus to fill the gap. And I would also take up your point about when you do visit, if you're lucky enough to get an invitation and you bother to turn up, you do want to see a GP. You don't want to see some nurse who's more akin to taking blood from you in a GP surgery. You want to see a GP who knows what they're talking about. Well, you hope they do until you listen to Dr. Doddy, and then at times you wonder whether they do. And certainly not a pharmacist. I know pharmacists like to think that they are as good as GPs, but they count out pills by and large and dispense medicines. They are not medically trained, and we shouldn't be using those as a fail-safe or fallback situation. So just a few observations, because this isn't really scrutiny. It's like a continuation of the old adult social services committee. Nothing to do with scrutiny. This isn't this morning again. Very, very disappointing. A few observations anyway.
Thank you. I don't know, let's come back on that. Yeah.
Yeah, happy to. Yeah, thank you. The age, the 74 limit, is a nationally decided age, and I don't know what the logic was for that. I think the point of the programme is early intervention. By the age of 75, I assume clinical colleagues will correct me if I'm wrong, but you're probably more on the radar than a 40-year-old smoker who's obese. On the radar. You're more on the radar of primary care, probably.
I don't think I'm on anybody's radar. They never get in touch with me.
Anyway, it's nationally mandated. We don't have any influence over that locally. In terms of performance, you're quite right. Ideally, it would be higher, and we've worked very hard to increase that performance. It's not great nationally, and the reason 100% of the population isn't invited is because it would be way too expensive to pay for the checks that are undertaken, and primary care, who are the main providers, wouldn't be able to cope with the volume. And that's why we target it. It's a kind of proportionate universalism where those more at risk are picked up earlier. But you are right, and we do try to increase that performance. And I think invitations is an area of weakness, and we do try to encourage practice to invite more. Without paying them to do so, we can't. We have got no contractual lever to force them to. It's up to them. But we do try to encourage, and they know themselves that it is better to intervene early and find the problems before the acute stage. So, but yeah, I take that point, and it's received. In terms of pharmacists, we have a small provider, a pharmacy. They're well qualified to do the tests that are required, and to give the lifestyle advice. But if there's something serious, then they will refer back to the GP, and the GP will take the case up from there. Thank you.
Thank you, Chair. To the GPs, Dr. Duddy.
Thanks very much. I think in terms of the people over the age of 75, the core NHS nationally agreed contract requires GPs to give an examination to over 75s on a yearly basis with a named GP anyway, except for Councillor Owen, who has been specifically taken off the list. But it exists, like most things in the NHS and social care, in a different area and therefore the duplication that would be required is of no use to anybody. I think one of the messages that comes through loud and clear year after year after year is that it doesn't seem to matter what you do with your NHS checks, you never seem to get any better. And it may well be that there are mutterings that says half of the people who get an invite and half of them turn up. Why are we doing it? Is this not a perfect example of an area that's persisted because it exists rather than because it's actually been proved to be of any use to anybody? All of these areas are covered by a variety of other indices such as QoF, quality and outcome frameworks, etc. And therefore perhaps there isn't seen as a great value in it. So do we continue it and spend the money on something that we have always done? Do we limit it to, as was said there, some of the target inequities that exist within Nottinghamshire? Or do we stop it and come up with a completely new programme which may be more attractive and may actually bring about better results? I think one of the things that we didn't quite move on to there was the digital offer, and throughout all of the other areas that we look at, whether it be bowel screening for cancer, sending out fecal occult blood tests, whether it be the offer for sexual health, which has gone largely online and has a huge increase in chlamydia self-testing, etc., etc. The technological level around which this offer should occur probably is the thing that we haven't really delved into in any great degree. Everybody who comes in for blood pressure now, with a dubious blood pressure, we actually give them a cuff free. So take that home with you. Here's a chart, fill it in for 14 days. People are used to doing that. My GP sends me something on the app regularly to say what's your height and what's your weight and how much you're drinking and all that sort of stuff. We're used to COVID testing over the last 2 years. People are very adept at self-testing now in a way in which they probably wouldn't have been in the past. And therefore I think success going forward, regardless of capacity, has got to be moved towards the digital offer, which is occurring on all other services, and we're doing it elsewhere. But we seem to be stuck in some sort of a rut with regards to this. As Councillor Owen pointed out, pharmacies. Every patient who goes into a pharmacy will get a call saying that they're emergency because their blood pressure through the roof and they're going to have a stroke, because they're not set up to take blood pressures in calm surroundings. It's because they're not set up with the proper offices and the proper privacy, etc. It's quite right that these facilities are not there in a functional manner. We've always wished they were. We've always hoped the pharmacies would take up the slack and move forward with them. They're good at some things like flu vaccines, but in terms of this. And lastly, I'm going to say that there are a lot of core competing services out there doing exactly the same as this. And most recently, we were selected as an accelerator site for the core 20+5, where we look specifically at the 20% most deprived people within the whole of Nottinghamshire. And we were selected as the hypertensive element of the +5, and the 7 ICS selected are getting together next month here. And we're presenting the work that we're doing as a council around blood pressure in particular, etc. So there are competing providers of exactly the same information, perhaps achieving better successes than are achieving with this. I look forward to the core 20+5 national initiative being operated through local systems to reduce the incidence of stroke and atrial fibrillation, etc. So perfect, as I probably think most people are thinking, that this is really something that needs a big shake-up. Thanks.
Thank you, John. I don't know if there's really a question in there, but it's just an observation. Would you come back, Jeff, or shake-up?
Yeah, thank you, and thank you for the points raised by Councillor Doddy and Councillor Owen, and you do make some really good points in terms of we have an opportunity cost with our public health grant. We can only spend the money once, so we want to spend it so that we have the best outcomes for our people in Nottinghamshire. And I think there's a lot of changes going on nationally around the NHS Health Checks programme, and that will provide us with opportunities to look at this differently. So I think the digital option, we are seeing the COVID pandemic has really given us some really good opportunities to test the digital market and test the appetite with our population around how they respond to digital options. And I think that's going to give us some really good leeway in terms of then thinking around how we really embed that equitable approach. So how do we make sure that we're smarter with the money we've got to actually make sure that we're diagnosing the right people, and really increasing the proportion of people that we're identifying with that Q risk score of over 20, so those people with cardiovascular disease or potentially diabetes and other conditions in an early way. But I do think we need to take as well the opportunities that we've got across the system in terms of looking at that innovation and looking at how we do look at other areas of the system. So yes, pharmacy may not be right there now, but actually some of the results that we're getting from our opportunistic pharmacy provider are actually having a really good conversion rate in terms of the number of people they're screening to the number of people that they're actually diagnosing at high risk. So I think there will be changes in terms of how we approach health checks, looking at how these national and local changes come into place, and hopefully we will see that actually it may not be that we invite more people, because it might be that from a GP point of view that they haven't got the physical capacity to do that. But actually what we're more bothered about is not necessarily the people that we invite, but we're more bothered about the people that we identify with cardiovascular disease, because that is really the outcome that we're looking for here. And as I say, lots of opportunities to explore that in the future.
Thank you. Mike.
Thank you, Chairman. Jeff, I'm sorry, I can't see your second name. Appendix D, 1, 2, 3, 4, 5, 6.6. Is broadly similar regardless of the deprivation level. Yeah, at the end of that. So that's a positive, I think. But are the health results similar from both sectors? I'd be really interested to find that out. So I think there's a detail in there which sort of diverts away from those at the lower end of the scale. I'm not sure. I can't see anywhere where we hold any data referencing the employment status of those that we're talking about of this age, because we're still obviously heavy engineering will have a high impact presently, probably for the next 10 or 15 years, I'd have thought. And on the eligibility, I would have thought anxiety would have been a huge question about CBD, especially from a mental health point of view, and I can't see anything that engages in that, so I'd be interested to understand that.
Thank you, Mike.
Jim? Thank you. So it's a very good question about the deprivation outcomes, and I don't have that data here. We can provide it, we can dig it out. So I can't give a definitive answer. It's highly statistically, using kind of global research, you would expect the outcomes to be worse the more deprived the area because of the modifiable risk factors such as smoking. But I can't say that definitively for Nottinghamshire because I don't have it with me. So apologies. No, it's good. Employment status isn't part of the template, so they're not asked about their employment status, which we'll take away because it's a very good point. I'm pretty sure it's not on there. And anxiety, there are annual health checks for people with serious mental illness, which is a separate thing. And there are I think there is a question around mental health in this health check, but it doesn't contribute to the Q risk score. So it's a conversation point for the clinician, possibly for referral, but it doesn't contribute to CVD risk as far as the Q risk algorithm is concerned. Yeah.
Thank you, Jeff. Thank you. Reg.
Thank you, Chairman. I'm coming back to where Councillor Owen left off. And 74 over excluded. So I'm excluded from what you've been talking about here today. And I don't agree with that. And I would like to think that somewhere through this scrutiny we can get a referral back to what they call government view of NHS Health Check to say why, as at 74, are a large proportion of the population excluded from NHS Health checks, and I mean a lot of it's been through there, and you know we just really got to take that up so that we're not excluded. I mean I've been just through a situation myself personally. I had almost to force the issue because I wanted to know how my health is. I live alone, and now I need to know that you know my health's going to be all right, and if there's a prevention that I need to be doing, I need to be doing it. And I know there's lots of other people in the same situation because we do gossip about where we are after a certain age and all the rest of it. And I think up and down wherever you talk to people, we need to get this more expanded to the more the older generation. I think a person 60, 70, 80 plus is more likely to have a health problem than a 40-year-old because a 40-year-old should be able to look after themselves. I know I did when I was 40, you know, go jogging every day and you keep fit. So for me, I think the key of this thing, of what's all gone through there, means that after 74 you're excluded, and I totally disagree with it, and I would like somewhere through this review that we can go back to this health check, government review of NHS health checks, and see what can be done to include everyone, make it inclusive.
Thank you, Reg. Yeah, you don't look a day over 70, but can I just, I think it's the criteria. Jonathan, you'll look on this, say the criteria is government set, isn't it? But have we got any influence of sending recommendations?
Chair, you're quite correct. For this screening programme, the criteria is set nationally for us. But if we take a step back for a moment, Council, although it might not feel like it at times, for someone who might be aged more than 74, actually, I think you get a better deal than through this screening programme because of what general practice is required to provide for you. But this screening programme is about identifying people who are at increased risk. It's not about managing the healthcare of people who are aged 74 and over. That does sit with our GP colleagues. It's something I think that Councillor Doddy referred to earlier on. There are indeed other screening programmes for checking out other risk factors. This one is focused on a particular age group who otherwise would miss out and might not have their high risk identified. Notwithstanding some of the other comments that have been made about how we might improve things nationally, in Nottinghamshire, because of what we have got in place at the moment, every day of the year there is a person being identified at high risk who otherwise would not be identified, and so becomes able to access some interventions through a doctor for something like raised cholesterol or hypertension. If it were not for this screening programme, those people would not be identified at the moment.
Chairman, can I come back on that? Because my GP practice has not contacted me in the last 10 years about anything at all. So wherever this prevention is that you're talking about, for those once you pass a certain age and all the rest of it, I've been in the other age group, now I'm in the other age group, there's been no communication. They haven't summoned me and said, oh, we need to do a health check on you so that we can prevent you ailing in the future.
Yeah. So I think what you're recounting is a potential very considerable and significant concern in the local system. It is something which, because it's commissioned from the NHS, my suggestion would be that it's best taken up by the Health Scrutiny Committee rather than this committee, which generally is looking at what is commissioned by the local authority. So, Councillor, it's not to dodge the thrust of your very important observation, but I believe the matter will be best dealt with in health scrutiny.
Okay, Jonathan, we'll have to pass that on to Councillor Saddington for you. Okay, thank you. Paul.
Thanks for bringing me in, Chair. I don't think I actually have a 74 cancer on. You don't look it, mate. You must have had a steady life. So anyway, I know the situation. I know I am. The situation is in relation to this. I mean, if we look at it logically, I mean, are you in favour of screening programmes per se? I think we should be. because there are numbers of NHS screening programmes that are in operation now throughout the country. Breast screening comes to mind, and I know there is a big thrust and programme towards getting men screened for prostate cancer as a screening programme, not just going down to your GP and having a discussion. So I think screening programs are valuable and are worthwhile, and they do pick up people that would present a risk. I've just recently been for my check, and I won't tell you exactly what percentage score I got, but it was relatively low. So I was quite happy that after all the questions and honest answers that I gave, I came out relatively low. But in saying that, I think one of the main problems is actually how we encourage people and the report highlights it, in the more deprived areas to actually participate in the screening programme once they've been offered to go. And we've all sat around in this council and in this committee and in other areas where we have a certain amount of influence to try and encourage people to live a more healthier lifestyle, to exercise, to eat sensibly, to stop smoking, and that includes stop vaping in that. But sometimes things that you suggest fall on stony ground. But that shouldn't detract us from keep repeating the message and keep trying to encourage people to participate in the programmes. I feel, and it's highlighted in the report, that one of the main problems is the amount of deprivation that we've got. The areas that are more deprived tend to respond less to all of the things that I've said. So instead of standing away from them and thinking, well, we shouldn't approach them because they're not valuable, they're not worthwhile, we should be encouraging them more. We should be focusing more on those areas to try and improve the uptake. I mean, it's been mentioned about using various other establishments rather than GPs to conduct these tests. Now, a few years ago, we went to a GP and there was no practice nurses that could prescribe. There was no practice nurses or members of the team that could actually have a consultation and make recommendations. But people have been trained. They took some pressure off GPs, and now the GP practices and the staff are more rounded, and people can actually, if they can't see a GP, they can get treated. So the similar thing applies to pharmacies. I mean, all through the pandemic, we were getting injections through pharmacies. Pharmacies, once they're trained, or pharmacists, should I say, once they're trained, are quite capable of undertaking a test and putting information onto a system to determine how you come out. So I wouldn't exclude them from participating in this process. I'd just like to think that as a scrutiny committee, we say that we value this NHS screening programme, but there are limitations, and we should be encouraging people to participate through whatever means we can as a council, and encourage people to actually get the test done, and hopefully then reduce their risk. People sort of go through life, and it's been mentioned about the elderly, and it was a few comments in the previous paper that we discussed. The problem with having an elderly population. Well, I think we should look at the positives of having an elderly population. Look at the vast amount of experience and life stances that the elderly populations bring to the community. So we shouldn't dismiss them. And I think Councillor Adair is right. Sometimes if the elderly population feel excluded, then it should be part of our job to make sure that they're not. But one of the main things I think is we've got to encourage governments to reduce deprivation. They've got the figures, they know where these parts of our communities are, and with all the amount of levelling up that's coming in, we should be able to reduce deprivation and thus improve the health of our population in Nottinghamshire. Those are just a few comments, but I think we can make a couple more recommendations, Councillor Jackson, in a minute. Thank you.
Thank you, Paul. Yeah, I think Martin's got those. I think it is very important that anybody who is invited, they are encouraged by family members, or it needs to be advertised as well. You know, we've always said prevention is far better than cure for everybody. You know, it's just encouraging people. One or two people look a bit frightened of going because they don't want to know the outcome. But then again, you know, early prognosis it gives a good outcome. I've got everything. Then I'm going to give Martin to finish off. Yeah.
Yes, thank you, Chairman. It's on that very point about getting the right amount of getting everybody looked at. Really, is the issue, and the program's been going on for a while, and you'll have data available from who you have selected, who you have invited, who have not taken part of the test, and people who have taken part of the test. Are you able to match their current health situation to the data based on those on that selection process flow, just to actually show that the people that have been positive and taken part in the program have better health outcomes? And I think by having that message to the people that are not turning up or not accepting the invite should be doing so.
Yes. We haven't. It would be a massive piece of research to do it on an individual patient basis. So no, we haven't got that. But you're absolutely right. What we do know is that of those that do go for a health check, we know the percentages that are diagnosed with XYZ, which they wouldn't otherwise have known about because they're usually asymptomatic. So we do know that, for example, I can't remember, it's in the report, 3% have cholesterol, and the highest is usually obesity, around needing to lose weight. So there is, and I think I wish I'd included in the report a case study or two, because I think there was one that ended up in the Mansfield Child actually, about occasionally there are lives saved by people they forget the GP, they go straight to A&E actually when they find the heart problem. And it would be fascinating to do a really deep dive into actual patient outcomes for those that haven't taken up the offer. Logistically, we haven't been able to do that. But it's a valid point. Yeah.
Thank you. Thank you. Vice Chairman just wants to say a word.
Yeah, I'm a bit of a loss as to understand really why this screening programme has fell into this category. I can see the general health check is why it's done by a GP, but compared to other screening programmes for other issues, all other medical issues, it's open to all. And I think the reason it's floundering is because it's currently GP led. So it's the GPs that send out the letters, the invites to whichever age group they are, right? And I take your point, Reg, and Councillor Owen. I take your point there. But it is an early intervention screening programme. That's the difference between what you're talking about. And I do think that we need to facilitate it in every way. So I'm glad to hear what you're saying about technology leading here, because I presume that those that get the higher Q risk then get referred back to the GPs and into the NHS system. But I do struggle to wonder why it's not been delivered. Important issue, and it affects a lot of people, and yet only 29% of those, whoever's been invited, whatever percentage it is, we've only got 29%, and it's been like that for the last 6 years that I know of. In fact, that's how it's been for all that time. So if we added each one of those years up, how many people's lives we could have saved if we'd have achieved a higher screening rate. And I know you're targeting people, but it's a very difficult thing to assume that just because somebody's of a certain build and lifestyle that they are going to get affected by it, because it can affect people who you wouldn't perceive that were going to be affected by it. And of course, deprivation levels and education are the same sort of thing, and it's those areas where it's required more. So perhaps we could have a more targeted approach in the higher deprivation areas to encourage people in those particular areas, and try a different a different route of delivery, because it's just not happening at the moment. And technology is going to help it massively, but only by those people who can be bothered to do it. And it's those people who can't be bothered to do it that's probably going to be more adversely impacted by it. So I definitely think we need a little shift and a bit of targeting, because it's money we're spending through the county, and we're flatlining around 30%, and it's been there for, like I say, 6 years, and it's never got any better. And prevention is better than the cure. Of course, the adverse impact is we end up with an older generations living longer, and that's the other side to it. So there you go.
Thank you, Dave. I think unfortunately that 30% figure is a national figure as well, isn't it? So
yeah.
it's difficult to think. I don't know whether you want to come back on that at all, Vivian.
Yeah, thank you, Chair. So just I think you make some very valid points there. I think we always have a very difficult conversation that we have to make around any of our resources, around the best way to utilise our resources, don't we? So we would love to be able to check everybody, but unfortunately we just wouldn't be able to afford it, and we wouldn't have the workforce to deliver that. I do think, though, the way that you're talking about that in terms of having some more targeted approaches, I think we're already looking at some green shoots in terms of that. So, as Councillor Doddy, we are part of the Core 20+5 Accelerator site, which is looking at hypertension. And hypertension is a key risk factor in terms of cardiovascular disease. And within that, we are looking at how we can use more innovative approaches and really work with our populations, and particularly looking at our most deprived communities, and acknowledging that different communities are going to need a slightly different approach. And I think the opportunity that we've got with that particular pilot is to test some of that. And we'll also be building on some of the learning that we've had, through COVID. So if we think about some of the opportunities that we've had with, say, the COVID vaccination programme, we've never targeted populations in a way that we've ever done before as what we did through COVID. And certainly some of the work that we're doing with Jeff and the team in the broader public health department is using some of that learning to think around how we deliver things in a different way, so that we do target populations in a different way that's right for them and that works for them. And really we're linking in with our place-based partnership colleagues and our voluntary sector and our communities around what does that mean for them, why is it important to them. So just to sort of provide some reassurance that we're not there yet, we've still got lots of work to go, but certainly by having the more digital option coming here, we will have that universal offer, which will allow us to have more flexibility around how we can have some of that targeted offer, but acknowledging that some of the biggest population changes that we need are about shifting the whole population and not just targeting the end. So it's about trying to find the mix, I suppose, to make sure that we are getting the people that need the services the most.
Thank you, Vivian. Matt, you want to win?
Thank you. Just to close, I wanted to breathe in a bit of positivity to the conversation. I want to thank public health colleagues who are doing the work they're doing, which I have no doubt has resulted in saving lives in Nottinghamshire. I myself have a very minor heart condition that was picked up in a screening programme. Had I not been part of that screening programme, it would have been picked up, and the consultant told me I probably would have dropped dead at some point prematurely. So I'm grateful for having had that picked up. I've also been attending quite a lot of the social prescribing groups, which are meeting across Nottinghamshire, and some of the support groups associated around stroke and also heart disease and other conditions. And I've met a number of people now who are in their late 30s, even early 40s, mid 40s, who've had heart conditions, heart complaints, heart attacks, strokes, and their lives are fundamentally affected. And I'm sure we can all recall being at school and some of our friends suddenly one of their parents inadvertently dropping dead. So although this has been a long and slightly dry conversation, and although there's pitfalls and there's challenges and it's not perfect, the data we can't see is the number of lives that have been saved as a result of this work, and I have absolutely no doubt that there have been. But what we can see in terms of the data is positive as well, in that although we're sending out less requests than other areas in England, we are actually getting a higher turnaround, significantly higher actually than the English average. So I think we should congratulate ourselves on that respect, and I certainly thank the team for the work you're doing. Finally, just to throw in some conservative credentials here, it's not only about saving lives, which of course is so important, it's also about saving money. And with my adult social care hat on, the best thing we can do is prevent. And on a preventative measure, again, the long-term effects of finding these things not only mean you're alive, but it means that you are not needing to rely on the services and the systems that we're here to provide as and when you do need them. So Just to end on a positive note, if you allow me, thank you, Chairman.
Right. Very quickly, Paul.
I'll be positive when I'm speaking, Matt. I don't know. Anyway, I mean, the recommendations in the report says that the Select Commission considers and comments on the activities being carried out to implement the NHS check, and I think we ought to comment that this committee supports the screening programme and its continuation. So that's one recommendation. Two, we look at ways of improving take-up in areas of deprivation. And three, touching on Councillor Deere and Councillor Owen's point, that refer the issue of age-related eligibility to the Health Scrutiny Committee. Thanks, Chair. I think they're positive.
Francis, I was trying to wrap this up very quickly.
Very quickly, Mr. Chair, but I think it's important we put this on record so I know where we stand. This is an important committee, and despite your talents, I suspect the public aren't gripped by its proceedings, and there's probably not millions listening. But there is one group that's listening to this committee, and that's the press, and they are extremely good at communicating what's been said. And what I'd like to ask, Mr. Chairman, is do you agree, and does the Cabinet member, Councillor Barney, agree with Councillor Owen when he describes pharmacists as pill counters? Councillor Owen recently gave us an updated code of conduct which included beefed up civility and respect. I've not read in
Sorry,
there
Francis, I think that's
whether
a totally irrelevant
we have carte blanche
comment for this committee. It's not
permission
progressing
to
anything
insult other
forward.
respected organisations in the health infrastructure of this country. So I'd just like to put it on the record. Do you agree, and does the Cabinet member agree, with Councillor Owen's opinion of pharmacists? Thank you.
I don't think there's any need to answer that question. I'll move on to ask Martin to read out the recommendations, please.
So hopefully we'll kind of get there. So firstly, that the report be noted. Secondly, that the committee would like to note its support for the delivery of the NHS Health Checks programme. Thirdly, that further consideration should be given to activities that can uptake the number of invitations and the uptake of the NHS Health Check programme, especially in areas of high deprivation. And that further work should be carried out to investigate the further use of the development of technological solutions to support the delivery of the programme. After that, there's a further report on the NHS Health Check programme covering the issues detailed above be brought to a future meeting of the committee at a date to be agreed by the chairman. And then finally, I'll word this up a bit better, but I didn't have time to get it down. That basically you're concerned about health checks for over 75s, that we pass that to the chairman of the Health Select Committee so they can consider that for inclusion on their work programme.
All members agree with the recommendations? Please show. It's unanimous.
Do you want to have 5 minutes? Because we've been going for 2 hours.
Sorry. Financial vision. I apologise. It's a little bit late, but I think we'll crack on, members. And again, invite Councillor Barney to present this report.
Straight to Mel.
Hello, everybody. So I'll try and canter through the issue. So, firstly, why should you be interested as scrutiny in our performance, risk, and financial position? Mainly because this is how you know, as a group of members, that within adult social care or public health, we're meeting people's outcomes and needs, and pretty much doing them in a way that you've talked about through the morning, about a way that's fair, that targets our support, and that is received as a good experience by the person. So hopefully we're going to bring to life some of the performance that you can make the linkage between the outcomes that people are experiencing and make some conclusions about that, but also inform the future work programme of areas where you'd like to know a little bit more. So Jonathan and I are going to give you an overview. Within the report that we presented, there's some more detail, and then any of the colleagues are happy to answer some of the questions. We do have some stories of difference within the presentation and within the report that tries to bring some of our performance to life. So, I just want to touch on the money. So, as I joined committee, I heard a conversation about the finances and the pressure that we receive. So, there's two areas of financial performance. One is about adult social care, but income and expenditure, and broadly, we're experiencing overspend and pressure within our care commitments. So, most of the money that we spend in adult social care, around 87% of it, goes directly to people's packages of support, whether that's through our own services or through services they receive in the social care market, as you heard one of our providers talking this morning. So most of that money goes directly to people, and we are seeing that the costs of providing that support have increased. So we're receiving some of the what we're experiencing within working age adults. The cost per person has increased dramatically because of the cost of care and the inflation that's experienced in the social care market. And then for older adults, and Sue can answer some questions on this if needed later, we're finding that people, particularly on leaving hospital, are needing more care than before the pandemic. So we estimate probably about, it's a bit odd to think about this percentage, but about 20% more care. So really that might mean that before I went into hospital, I was receiving maybe 1 or 2 calls a day. By the time I leave hospital as an older adult, I'm more likely to need 2 people to care for me and 4 calls a day. So we're seeing that that's been a real trend, that people have become leaving hospital more unwell, and that in turn is increasing some of our cost. At the moment, we're able to what we call mitigate, so underspend in other areas, particularly in some of our commissioning areas of activity, to offset some of those pressures of care. So overall, the financial position of the department is well managed, but we are experiencing those costs of the care that people receive. Just to touch on public health financial performance, you'll be aware that the public health grant is a ring-fence grant. It's around 45 million, and it provides the sorts of services that Jonathan and Jeff have been talking about today. We have got some uncommitted reserves that is come from previous year underspends, and Jonathan is having a look at the moment with the cabinet member and with Councillor Carlton to look at areas where we can address some of the pressures we receive in public health. So adult social care, the pressures are seen through finance, so you can see that, but public health, because it's a contained grant, the cost of inflation, the huge increases in requests for support we're seeing through things like sexual health services, domestic abuse, substance misuse, children's mental health. They're not seen in the same way financially as they are in adult social care. So at the moment we're having a look at how we can use the uncommitted reserves to address some of those public health challenges that we're facing. So we do track as a department what we call benefits realisation. So this is the areas where we're investing our resources into what we hope to achieve. So this slide just gives some examples of that. So this is about the outcomes that we expect to have on people's lives from some of the investments and service improvements that we've made. So one of the things that's been really important to us this year, as it is in most years, is our relationship with urgent care and how we support people home from hospital. So some examples there about some of the areas where we've had some success. So where we're trying to increase our reablement support, but where we're looking at low referrals from health colleagues. So Sue's undertaken some work to try and increase those referrals so we can make sure our reablement services are widened out to as many people as possible. There's another example on that slide that talks about the working age adults and with working to independence. So we've supported 315 people this year to increase their independence. So this just gives you, I think, a broad overview of the areas where we're hoping to have some impact. Preparing for adulthood has been a key area for us in the last 2 years, and this will continue to be so, and links really strongly with the Ofsted and improvement plans that were led by the Children and Family Service. So preparing for adulthood is about engaging with children and young people from the age of 14, so year 9, to support them, to enable them to seek work, live independently, start to think about moving away from home, all those things into normal adulthood that we know children with disability or additional needs face challenges with doing. So that's a piece of work that's being led for Living Well Services to make sure that we're engaging at the earliest time. And the piece of work that we're focusing on in the next 12 months is making sure we have those links with education. So at the moment, our transitions between children's social care, adult social care are really strong. Where we struggle a little more is to identify people who will be eligible for adult social care services, who maybe have only received health services or only received support at school. So that's the next piece of work for us to try and make that broader work on our transitions. So this is some of our performance themes. So we've talked about hospital discharge, so I won't reflect that more, but just to touch on adult safeguarding. I'm going to put my glasses on, it will be much easier to talk. We know that we're not achieving enough performance yet with the number of people we've asked about what outcome they're seeking from the safeguarding plan, and to make sure we understand whether their reasons for wanting support were understood. So that's a piece of work that we're really looking to improve, because really we should be working to ensuring that we ask every single person what their outcome is. At times there are some valid reasons why we can't ask somebody, maybe because they don't want to our support, because that's a common reason, or maybe they're not possible to articulate their concerns, or maybe they died and the safeguarding piece of work we're doing was understand the circumstances around their death. But what we're doing as a department is making sure we count the valid reasons that someone can't express their views as well as the valid ones, so we can really improve the performance there. Long-term reviews is a really important piece for us. So under the Care Act, we have a duty within adult social care to meet people's eligible social care needs and to review them at least annually. It's kind of a bit like a health check, I guess, for people with adult social care, to make sure their needs are being met and that their support plans are valid. So we're working really hard to improve the performance from around 80% at the moment to everybody. And this is because it's a very basic safeguarding check. So just making sure that someone is well, their wellbeing goals are being met, their support plan is valid, is quite important. Nationally, we perform really well against our colleagues, and particularly in the East Midlands, but we have a view that we want to really be offering this out to everybody. And we're using a very similar approach that described in public health about targeting risk. So we do that with reviews. So obviously we support about 12,000 people. Their needs aren't all equal in adult social care. So we try to target those we believe would be most at risk. And some people have reviews much more regularly, some people less so. Some people have those around them that can advocate fairly for them, some don't. So we're trying to take a risk-based approach to those reviews. Just to touch on a really important topic for me here, which is carers. So we've had quite a bit of evidence in this year that the support we're giving to carers is much less good than we would want it to be. So carers has been a really important piece, and Cabinet approved the carers strategy earlier in the year, which is a strategy that we share across with health partners and with the City Council to really highlight the needs of carers. And we know the pandemic had really catastrophic impacts on carers' quality of life, because it was a pretty lousy time, and for a carer it meant they really lacked that ability to get support, get out and about because of the conditions that we were all living in. But what we've seen in Nottinghamshire is that we haven't seen carers' experience recover at the same speed that other neighbours have had. So we've really taken a targeted approach. Through the big conversation, we've heard from carers that whilst they get good information and advice, they don't always get the support, that they would like to have more short breaks, and they would like to have much broader information and advice. The reflections from carers are that when we see them, the support is good, but sometimes they feel quite alone and don't know how to access that information, advice and support. So we've done a deep dive piece of work with our carers co-production group. Ainsley led a piece of work last week doing that piece of work to understand how we can start to accelerate areas of the strategy. We've got a huge amount of plans in place through the strategy, but there's something about making sure that they're starting to impact on people's lives now. So that's an area where I would recommend that you may want to have a look at into the future as to how successful that strategy is as we implement it. I think you heard a little bit about workforce earlier, and you were particularly thinking about the external workforce. In adult social care, I've got a responsibility for the council staff and also for the adult social care market. You heard about the former earlier, so I'm not going to repeat that, but this slide gives a bit of a flavour of some of the areas where we're focusing as a department. So equality, diversity and inclusion is really important for us. So one of the things that we've been doing in the last 18 months is what's called the Workforce Race Equality Standard, and this looks at the experience of black staff and staff from ethnic backgrounds, making sure that we're offering training, development, and that there's some routes of career development for them. That's been really important. We've also had some brilliant success with our mental health social work recruitment Think Ahead programme. So this is a national programme where we have a number of placements locally, and that's something that Ainsley and colleagues lead with our mental health provider trust. So it's something that we do with our partners. It's not something a programme that's county council led. I imagine you touched on recruitment processes earlier when Bridget was presenting, but we've looked at different ways of recruiting people. So rather than it being a traditional application form interview that takes very long and that requires quite a view of, a high level of literacy to resolve, for other areas of work, the caring is more important, that we're paying people to care, not complete application forms. We look at different ways to recruit, and that's really helping us bring people on board. Retention is really important, so workforce well-being is essential. So activities like that focus on equality, diversity, inclusion, also think about our well-being at work, and that is age approaches relating to age. So we've got new menopause initiatives for some of our female staff, because we're a predominantly female and older female workforce within the department, as well as things that focus on general well-being. So if you want to hear more about that, we've got our annual learning and celebration event in the autumn, and a big focus of the event last year and this year is about our well-being at work, because if you treat people well at work, they stay and they work harder for you. So there is a conservative edge to that as well, Matt. Quality practice assurance. We've had really good feedback about the strength of our quality audits. The local authority had our annual conversation recently, which is the annual check that we have in adult social care about how well we're performing, and the strength of our quality audits was noted. And there's some results there on that slide that describes to you about some of the findings of that. It's particularly pleasing about the adult social care worker focus on things that matter to you, and that in the large people agreed. That there's very few disagreements. We're yet to understand whether the agree or disagreement was about what that ambivalence about the social care worker was, but in the main we're getting good results about the quality and the impact we're having on people's lives. So I'll just let you read, I'll pause for a minute and just let you have a look at these stories of difference on the slide. And what we've tried to do is gather, I think, 2 examples of someone that was older and someone that was younger, to give you an idea about the breadth of the things that we do. And on that note, I'm going to hand over to Jonathan, who's going to talk through the outcomes we're achieving for people in public health.
Thank you. I'll just mention briefly then the 5 things that are highlighted here. First of all, you'll see from the report itself that there's a story of difference from one of our, in fact, a couple of our residents who used our integrated sexual health services, and I think it's something to celebrate in a way. When we read of a resident who comes along to a service, approaching the service feeling worried, anxious, and even the word the resident uses is one of shame, but came away identifying that there was real skill, not only in providing physical care, but also emotional support to a patient service user who was feeling all of that. So I think that's something to celebrate. The 0 to 19's Healthy Families programme, as you'll see again from the report itself, continues to perform very highly, whether we're comparing with England average or our statistical neighbours. One example of that being the very high level of face-to-face visits, which are achieved in the first quarter. That's 99.78%. Of all of them in the county, so that's again something I think to celebrate. The domestic abuse services, you'll note from this slide, many of them we were with cabinet members' agreement were able to give an uplift to, which reflects and deals with some of the inflationary pressures that many of them have been facing. over recent years, and I think councillors will be pleased to hear that we have now been able to attend to that. Finally, just to flag up to you then, in relation to our all-age substance misuse service, there's a kind of a glass half full, half empty thing to this. The very positive thing is that we are overperforming in terms of those the numbers of people that we're able to bring into treatment and recovery. And I think that's a very positive thing for Nottinghamshire. It does, of course, remind us of the enormous amount of unmet need as well, and the importance of the council continuing to invest its public health grants in providing support for people who want to exercise some extra control over their use of alcohol and drugs. And I think that's it from me. Back to you, Melanie.
Thank you. Just to touch upon some of our key risk areas. So these are the areas that we're concerned about as a department that are threatening some of our delivery of services. So I think the one that particularly I'd like to highlight, and we've talked about it here before, is the waiting times for some of our support services. So we've made some brilliant progress through our operational colleagues of reducing some of the waiting times. But we have people who aren't getting a service in the timeliest way. So I think as I joined, I heard Councillor Henshaw talking about some of the resource restraints that we have and it threatening ability to carry out the duties. One of the key things we're still struggling with is people waiting for an assessment. So what we do is we have a really robust way with an ethical decision-making framework and a risk framework of prioritising people that we know need the service most quickly, but nonetheless it means that things like lower risk reviews, lower risk pieces of work we're not undertaking in the way that we would like, in the timeliness that we're expected to see in Nottinghamshire pre-pandemic. So that's still one of our key risks. We also still have some risks with adult social care reform. So adult social care reform is paused and there are lots of elements that are still progressing. So there are elements that are still like the cost of care exercise and the other work that Bridget has presented before. So with the changes to government level and the pausing of issues, it means we're not sure when things will happen. So we've kind of got this bit of a lack of clarity around some expectations on us. And I think the other risk I'd like to flag is just around our data. So we have what's called client level data now in adult social care, which is where we have to submit information on individuals to the Department of Health and Social Care. And this is part of the CQC assurance process and moving to understanding outcomes at an individual level. Because of our systems that we have in place in the council, and we know we're not alone with this, this is across other councils too, we're really struggling to meet some of those requirements and particularly have improvement around data quality. So we have improvement plans in place with this and we are working with colleagues from the wider organisation, but nonetheless that is a risk to us, particularly thinking about the advent of CQC assurance. So like I said, a bit of a canter through some of the key issues I wanted to flag in the report, but equally we're really happy to answer any questions of the written report or indeed anything in the slides I didn't touch on directly.
Thank you, Mel. Thank you, Jonathan. Yeah, a very good report, quite in depth, and I believe we're going to get these on a fairly regular basis for this committee going forward. So we can also comment how we want to receive these reports. I will comment on some of the print is very small, unless we read it on screen, where there's a way of getting around that to transferring it to paper reports from the normal, because it is very difficult to read some of the figures on there. Any questions? Philip?
I'm only going to make one point, Chairman, on page 49, the smoking and vaping prevention programme for secondary schools. I think this is an area, smoking and vaping, where we could actually do the job that this committee is supposed to be doing, and that's do some scrutiny. We've got no real detail there. We don't know how effective it is. We don't know what the costs are. And I know you've got the work agenda later on, but I thought it appropriate, and I will make further comment there. But I thought I would draw your attention to that one, Chairman. I think that is an area where we should be doing some scrutiny on the cost effectiveness of it. It's been on the public health agenda for years. A lot of money's gone into it, and we still don't know how effective it is. Thank you.
Thank you, Philip. I think this committee has done previously quite a bit of work on vaping and that, but yeah, going forward, something to look at. Paul.
Following on from what Philip said, I'd be interested in looking at which schools, unless it's in the appendices, but I couldn't read them. They were that small. But anyway, yeah. What I'm saying in relation to the vaping issue, because I've often thought that we need to do a lot more work to encourage younger people not to vape, and indeed anybody. But I understand the reasoning why we went for it, because of in some situations it's better than actually smoking tobacco. But I think Philip's right. We need to own in onto this and get a bit more information. I was going to talk about a couple of things, but public health thing on vaping, the issue on oral health, it mentions that there were 2 jobs created. I just wondered if, Jonathan, you could sort of highlight what those jobs were and what were the job descriptions and duties, because obviously working with people in any situation, oral health is very important, especially in the care setting. You want to make sure people do, where possible, clean the teeth and make sure they have regular checkups if they can get to see a dentist. And I know a lot of people do use the community dental services, but similarly, I've known dental practices send letters out to people with a learning disability saying that they're no longer providing NHS services. You'll have to be paying £20 a month from now on if you want to keep coming to our dental practice. And so, the issue is very topical and very important. I wanted to come in on to the main thrust of the report. I mean, I think it's very important. In fact, we could spend one entire meeting and to do this report justice, because there are some very, very important issues in relation to the discharge figures that we've got. I mean, what do you think the reasons are why we can't sort of meet the targets of 70% and only getting it at the 34? Is it a problem with the discharge process, the round the table meeting, or is it people saying that we can't accept people out of hospital because it would be an unsafe discharge? So it's just something I think we need to look at and sort of make some comment on. The other one was the deprivation of liberty safeguarding, where and the report honestly says that we're not meeting our statutory duty in relation to assessing the Dole's assessment. So I just wonder if there was any way or what is in place to make sure that figure increases. I'm not being critical at all. I think there's a lot of positivity in the report, but I just think there are things that we could possibly look into in a bit more detail. Thank you.
Thank you, Paul. We will bring this paper back and bring it. Jonathan. Oh, sorry, Vivian, do you want to?
Yeah, thank you. It was just in response to the oral health question, if I may, Chair. So just looking at the report, I can get some more detail for you if you need to. But I think one of the we've got a new provider for the community dental services, and they're providing a range of training for a range of colleagues across Nottinghamshire in terms of supervised toothbrushing and oral health promotion. So the 2 jobs that have been created, I would imagine, are within that sphere, but I can get confirmation and come back to you on that. But I think one of the things that's really positive around that is that we are looking at how we really increase that social value element of our contracting. So we're not just thinking around, how many sessions are they delivering, but how are they reaching into their communities and to the people that we serve to really support those building blocks of good health, because we know that good work is really good for health and well-being as well. So I think it's really positive that we're seeing that, and I think we're quite keen from a public health focus to really bring some good news stories around that. I know the ABL or another providers that do a lot around that social value element, but on that specific one I can give you some more detail afterwards if that's okay.
Thank you, Mr. Chairman. Paragraph 5 tells us that we're running at 2.86 million over budget, and paragraph 52 tells us that as of March 23 there are 341 vacancies. My question is, Mr. Chairman, do we have theoretical figures if we were running at full employment, what the overspend would be, which might be useful towards considering next year's budget? And also, as a responsible employer, I'm sure we are concerned at the pressures on the services to the public with such large numbers of vacancies, and also, which may be the same or may be slightly different, the pressure on our staff in taking up the capacity issues. Thank you.
Thank you, Francis. Who wants to stay on?
And if I might, Chair, just answer the question about dolls that Councillor Henshaw asked. So, so during the pandemic, because we weren't able to access people's accommodation, we created a long backlist and waiting time for dolls. And Nottinghamshire, I think we'd had quite pride that we were one of the few authorities that was completely on top of dolls before that point. So Sue is well aware of that. We have a recovery plan in place. And that's included going out to contract for different providers for some of the elements, because there's a doctor element, there's a BIA element, so we've gone out for different elements. So we have got a recovery plan in place, but nonetheless, because we're not doing those in the way that we would like, it's a key risk. Councillor Purdy-Horan, just to come to your point about the cost of that, so it would depend on, I think there'd be a balancing off amount, because in the social work roles and essential roles, we're using agency staff, which are a higher cost than a established permanent person. So there would be, if we were fully staffed, I think it would net off. There is some benefit to having some vacant posts. We are holding vacant posts in both commissioning and in provider services to offset some of that expenditure. But I think generally it would net off. I wouldn't see that if we were fully staffed, it would give us a big financial pressure. I think where we would feel it would be some gains in some of the processes. So we know that using agency staff, some agency staff are brilliant, but it's not the best way it's not the most effective way to run a workforce unless it's planned. If you're using planned temporary staff for some initiatives, it's effective. Does that answer fully the question about the capacity?
Thank you. I think also, perhaps I didn't make myself clear. Do you feel that there is a significant pressure on any element of the service that we provide to the public because of the vacancies or agencies assisting in that?
I think it's less so about vacancies and more so about general wellbeing, particularly in the social work services and some elements of commissioning. I think public health, we're feeling more that we've got now, that we're feeling more fully staffed and equipped. But certainly right across the department and indeed across the council, we're seeing much higher numbers of absence due to mental health issues and musculoskeletal. So staff absences have continued to stay high post-pandemic. So I think that there is something about some vacancy in the staff teams, but more so about well-being and then covering for staff who are absent, particularly repeatedly absent or long-term absent. So we do have some concerns about that, and that particularly I think is impacting on our waiting times, some of the services. And what So and Ainsley do in their areas is when we've got an area that's a priority, safeguarding is a good example, or maybe the approved mental health practitioner service, we do expect staffing capacity to be focused in those areas because they're our riskiest bits, and that will then leave the teams doing other areas feeling more pressure. So that's kind of how the pressure tends to materialise. But we are having some success, particularly with community care officers and some of our reablement staff. We're seeing huge success with recruiting there, which is helping the workforce wellbeing.
Thank you. Mike.
Thank you, Chairman. Financial question. Recognising that adult social care and public health are looking at 2.86 in Q1. What's the clarity on the transfer to grant reserves or from grant reserves? Because I can see we're 130k out initially, then it went up to 65k, and then there's a final forecast variance at 75. If we hadn't seen that or need to clarify the 2.5 million transfer and how that would have impacted on the final figure, 2.86, had we not done that. Second question, because it's Q1, I recognise the underspendings which we'll lose, but I think there's a concern of 4.96 in the long-term care. They overspending that. What are we doing to address that? Thank you, Chair.
So I'll comment, and then maybe Jonathan could comment on the public health grant. So broadly, as a council, we have seen some benefit from short-term government grants in both adult social care and public health, and to the council. So, and I think some of that is seen in the accounts. If we hadn't had that, and Bridget's talked about the Market Sustainability Fund, Sue in the past has talked about the discharge funding, that has given us a benefit because we've been able to invest in some packages of support for people and also staffing. So that is, if you like, covering up some of the underlying pressures, as you mentioned, Mike. In terms of Q1, we are taking the usual mitigation. So Sue and Ainsley have got the usual processes of using our social work huddles. So that's where there's that high support, high challenge about someone's support plan in a team. So making sure we're doing things in the wisest way, timeliest way, and there's some support around the practitioner. So we're trying to get care right the first time. So that's a really important bit about managing the money, is making sure that people's care is appropriate to their needs. And then we also have the checks and balances. The important bit for our spend is the work within the commissioning team. I'm not sure if I missed the beginning, so I'm not sure how much Bridget went into this. We're making sure that we're getting the most out of our contracted providers. We're using the Market Sustainability Fund to use that against some of the pressures that we're seeing in the markets. They're our main mitigations there in adult social care. Hand to Jonathan.
Thank you. Thank you for the question. And I know you'll come back to me if I'm not addressing exactly what you had in mind. There were two things I was going to mention about the public health grant that you'll see some of this from the report. First of all, the work that we're going to be doing over the autumn to make sure that within the department, in year, that we're forecasting with the kind of rigour that you would be expecting of us. That's the first thing, and that work will kick off later this month, and I think we'll probably report in a couple of months' time or thereabouts. That was the first thing. The second thing, which is noted again in the report, is the work that we're undertaking to make sure that the public health grant is invested fully for the purpose for which, of course, it's intended, which is to improve the health of the population. And the fact that over several years we've ended up accumulating some grant reserves is not a good position, because they're not, while they're sat there, they're not improving the health of the population. So we've already got some things in train which will reduce the amount of uncommitted grant reserves in this year. And my team are working on some other things which I think by January time, as part of our normal budget cycle, are likely to mean that we come forward with some other proposals which will further reduce those uncommitted grant reserves for the future. I'm hoping I've addressed your question. I do apologise if I've missed it.
I think he's coming back, Mike.
Yeah, but you have, but you've raised another one. So if we recognise that there's public health reserves, and obviously we're coming to budget time, is there a positive impact even for this financial year coming that could be invested into adult social care from the council's point of view?
Thank you. So the answer to that one, in short, is no, in that the public health grant reserves have the same conditions, the ring-fence conditions applied to them as anything that we're spending from the grant in year. And in short, what that means is that this council, in common with every other local authority in the country, can spend its public health grant on improving public health, but not in terms of funding adult social care. Things that we are doing from the public health grant, which contribute and support Melanie's position, comes back to some of what we were talking about earlier in the meeting. There are a number of things. Cardiovascular disease, for example, much of which is preventable. If we don't prevent it, it means that people get sick and it increases the levels of disability and it means that people are unable to live independently for as long as, of course, everyone wishes to. And for some of those people, it will mean that they also become increasingly reliant on public sector services, including Melanie's services. So, of course, we are doing work around prevention, which supports Melanie's longer term financial position.
David.
Yeah. So I just want to concentrate on the staffing issues that we've got, because it's carried on from one year to the next, where we've got a similar level of open vacancies. Is that because of the level of remuneration for those particular jobs? Is it spread across the board, or is it in one particular area where we're failing to recruit? Or is it a rolling program where we've got people leaving and people coming in, and the figures remain at the same level?
Yes, it is a mixture. So a lot of the roles, a lot of it is people are leaving. We're seeing a lot of staff we've got a workforce that's approaching retirement age, but it's not, in the main, it's not the same job. We do have specific issues with qualified and then multi-skilled staff, such as our best interest assessors, who have to have qualified as a social worker, and our approved mental health practitioners, for example. But we've got strategies in place to manage those. But in general, it is turnover across our teams. Melanie referenced that the initiatives that we referred to in the slide deck, we are seeing benefits of those. So we've just offered, had a big recruitment campaign and offered 38 posts for community care officers who are unregistered staff that do assessments and reviews. So that's really positive. Also, if you think about it, we are investing, as was said, through the grants in extra posts. So we've got more post vacancies from, for example, the discharge grant and the market sustainability grant. But we're doing well with filling those. So it is a mixture, and we do have some rurality issues. So there's some of the more rural parts in the north of the county around Bassett Law and Newark. We've got a particular recruitment programme in those areas, and we are finding that local initiatives are having really positive benefits as well. So hopefully that's covered the query.
Thank you, Sue. Mel.
I think Sue's raised an important point that both for our social care market and for ourselves, although our actual number of vacancies are static, it's out of a bigger percentage. So we've got more posts in the council because of those initiatives in the discharge funding, and we're providing more care than ever before. So I think, Bridget, it's about 30% more home care we're providing overall in the last 3 years. So yes, we have got vacancy issues, but the numbers of people in post is bigger, if that makes sense. There's more people employed. So overall, we've had a gain. It's just it's not in, where we're aiming is also increased. So that's kind of what we're seeing, is that step.
Yeah, I was just interested to know, because obviously, if you've got a higher element of staff vacancies, it's going to have a detrimental impact on your staff you've already got. You know what I mean? Because it puts pressure on them. Also, as well, I forgot to mention earlier, we've got a jobs fair in Ashfield on the 6th of October. You know, and I think that's a good place, because I've had the pleasure of going to 2 careers fairs over the last 4 years, one for A levels and one for universities, and I don't see much adult health and social care being promoted at either. You know, and I think that's a real, because there's a vast array of careers within that context, and I don't see anybody standing there. I mean, not 4 years ago, I went around with six girls. I took 6 girls to a careers fair for university, and I didn't see one thing for adult health and social care. So I think it needs to be pushed a bit more.
Comment. Thank you, David. Well, I said this papers will be coming back, so we can monitor and have a look what the performance is like going forward throughout the year. So So this is the first time. So if finished questioning, I'll ask Martin to sum up with the recommendations, please.
Yeah, so nice and straightforward. The report we noted. Secondly, that the further report on adult social care and public health performance, financial position and risk be brought to the December 2023 meeting of the committee, and that a task and finished scrutiny review takes place to investigate the effectiveness of the work with schools around smoking and vaping, and obviously it's for the chair and vice chair to have a look at the scope for that. We'll be bringing something back about that.
Okay. All in agreement with recommendations? Thank you very much. It's unanimous. I think Martin's going to introduce this and see if members have any comments or suggestions for the work programme.
Yeah, so just really briefly, obviously this was the work programme that was approved overview last week. So it's been developed by working with officers who have presented big items that are being considered over next year, along with consideration of the vice chair, and obviously we did email out to yourselves to ask for suggestions, and also last year's work programme. So just to note as well, it is a fluid document, so we can add things on as things change. So if you do have any suggestions that come through over time, just let myself and the chair and vice chair know. But I don't know if anyone's got any comments now.
Yeah, Philip.
Yes, Chairman. I think we need to get on and do some scrutiny. And there's a couple of things that I would suggest. I've already suggested one. At Governance and Ethics Committee, we receive Ombudsman's reports where fault has been found. And there have been a number of Ombudsman's reports finding fault with adult social services. There have been two aspects. One aspect, poor communication. And I think there should be a scrutiny review of communications within the adult social services department, communications with the clients it serves. And secondly, I think there should be a separate scrutiny of the way in which the department deals with complaints procedures, because it's a failure of the internal complaints procedures that leads to ombudsman's reports, and particularly where fault is found. So those are two things that I would suggest. But on a general point, Chairman, I do not want to attend a further meeting of this committee of the sort that we have had this morning. There has been, in my view, little or no scrutiny whatsoever. Now, we have a cabinet and scrutiny system. Whether we like it or not, we've got that system. And we need to do the scrutiny side of it. What we've had this morning are lectures from officers to reports that would have graced an adult social services committee meeting under the old constitution. That is not what this committee should be about. We've had over 2.5 hours now sat here. Dr. Doddy's gone. He's lucky. He's gone. We've had 2.5 hours, and on my way home, I shall struggle to work out what we've actually achieved that's going to improve things for residents in this county.
Thank you, Mike.
Yeah, can we look at confirming the transition of service users from children to adults? It's on the work. It's on the work programme. Yeah,
It'll probably
be confirmed.
Because we've got the day opportunities one that we're starting. I think the meetings are scheduled for kind of like December. So when we've actually done that, we'll do that as the next one, because it's a joint one with children. So also we've got to coordinate them, and they've both got to slot in together. But that will be the next one after day opportunities.
Yeah, an important area. Thank you. Yes, we'll look into that. Yeah. If there's no other comments to be made, I thank members and also officers who are still here for their contributions with today's meeting. And sorry, Eric. Oh, do you want to vote on the work programme, do we?
Yeah.
Okay. All in favour of the work programme? So I apologise. I missed that out. Okay. And I bid you. I've apologised. It's been a long meeting, but I bid you all a safe journey home. Thank you.